So we will discuss about the coagulants, anticoagulants, thrombolytics, antithrombolytics, antifibrinolytics, fibrinolytic, antiplatelet drug like this. So already we have discussed about this, the fibrinolytic phase. What are the coagulants? Vitamin K important. What are the uses of the vitamin K? Local hemostatics. Now coming to the anticoagulant. So anticoagulation means just opposite of the coagulation. If there is any thrombus formation within the blood vessels, so there will be blockage. So when there is blockage in the coronary blood vessels, there may be heart attack, myocardial infarction. If there is blockage in the cerebral vascular system, there may be stroke or cerebrovascular accident. Similarly, it can happen to any peripheral vessels. So when there is thrombus formation or there is propensity of the thrombus formation, in those cases we have to use the anticoagulants. So you have read about these different types of the thrombus in pathology, I think. So arterial thrombus, venous thrombus, white thrombus, red thrombus. So you know about this. So arterial thrombosis, white in color, associated with myocardial infarction, stroke and ischemia. Ischemia means that is heart or any organ is getting lesser oxygen due to the narrowing of the blood vessels. So that may happen. Venous thrombosis mainly happens due to the stagnation of the blood within the blood vessels. This is red thrombus associated with congestive cardiac failure, cancer, prolonged surgery, etc. So this thrombus can dislodge, you know, you have read in the pathology also. So it can be formed as a embolus. So thromboembolism. So that embolus can be lost anywhere, any intersection of the arteries and arterioles. So there will be no blood or no oxygen will go to that organ. So there will be problem. So what are the available anticoagulants? So some anticoagulants are used in vivo, that is within body. For the diseases what we have discussed, it is used. And again, in the diagnostic purposes, you know that the blood is collected and it is taken in a test tube, and to make this blood fluid, some anticoagulant is also added to it. So these are known as in vitro anticoagulants. So in vivo may be parenteral or oral anticoagulants. Parenteral means injectable. Injectable may be indirect thrombin inhibitors like heparin, low molecular weight heparin, danaperoid, fondaparinux, etc. And direct thrombin inhibitors like lepidudin, bivalirudin, etc. Oral anticoagulants means that is given orally. That may be coumarin derivatives, bis-hydroxycoumarin or dicumarol, warfarin, acinocumarol, etc. There may be ferindam and there may be direct factor Xa inhibitor, the newer ones. So we'll discuss about this like rivaroxaban. In vitro means when in diagnostic purposes we have to add this anticoagulant to make it fluid. Heparin can be added. Heparin can act as both in vivo and in vitro anticoagulant. Calcium complexing agent like sodium citrate, acid citrate, dextrose, etc. can be happen. Sodium oxalate, mainly in glucose estimation, sodium oxalate can also be used. So mainly we will discuss about the in vivo anticoagulants, that is anticoagulants needed for prevention or the treatment of some diseases. So the same thing, so anticoagulants, again we can broadly divide it parenteral, oral, same thing again and again. So the target may be different. So target may be thrombin. When the thrombin is the target, the agents are the bivalirudin, lepidudin, argatroban, hirudin, etc. When the target is the thrombin and the factor Xa, example is the heparin, low molecular weight heparin, only factor Xa, fondaparinux. Oral, there may be thrombin, factor Xa and others. Others means mainly the vitamin K antagonists are used. Oral factor Xa inhibitor, these are the newer ones like rivaroxaban, apixaban, edoxaban, etc. Dabigatran is only oral thrombin inhibitor. So don't worry, we will read details about this. So first coming into about the heparin. So you have heard about the heparin in the physiology, biochemistry also. So heparin is basically non-uniform mixture of the straight chain mucopolysaccharides. So basically it's a glycosaminoglycans. So you have read about this in the biochemistry. Molecular weight, high molecular weight, approximately 10,000 to 20,000 molecular weight is there. It contains two polymers, polymers of the two sulfated disaccharide. One is D-glucosamine L-iduronic acid and another is D-glucosamine D-glucuronic acid. So these sulfated polysaccharides are added to one another and different long chains are formed. Mucopolysaccharides or glycosaminoglycans like structure. They carry strong electronegative charges and heparin is the strongest organic acid present in the body. So this is the strongest organic acid present within our body. It present in all tissues that mainly contains the mast cells. So mast cells mainly secrete the heparin. It reaches source of the lungs, liver and intestinal mucosa. So within the lung, within the liver and intestinal mucosa, there are mast cells, and that mast cells secretes the heparin. Heparin is the strongest organic acid in our body. It is a mucopolysaccharide or glycosaminoglycans that contains 2 sulfated polysaccharides, high molecular weight, approximately 10,000 to 20,000. Commercially, it is produced from either from ox lung or pig intestinal mucosa. So ox lung and pig intestinal mucosa are also very rich source of mast cells. So from this, the heparin is extracted, distilled, and accordingly the medications is formed. Now, how this heparin basically acts as an anticoagulant? So first remember, this heparin does not have its own intrinsic anticoagulant action. So it is itself is not anticoagulant, it helps in anticoagulation. So how it helps? It is a powerful and instantaneously acting anticoagulant. It acts indirectly by activating the plasma antithrombin 3, which is a serine proteinase inhibitor. So plasma antithrombin 3 is already present in the plasma. Heparin just activates this plasma antithrombin 3 so that there will be more interactions between the plasma antithrombin 3 and the thrombin as well as the factor 10A, and then the anticoagulation happens. So heparin basically accelerates the already undergoing chemical reactions between the thrombin and antithrombin and accelerates several folds. So it does not have intrinsic anticoagulant action, it accelerates the normal anticoagulation that is ongoing in the plasma. The heparin antithrombin 3 complex then binds to different clotting factors. You know the different clotting factors? Mainly it acts on the intrinsic and common pathway. So factor 10, 2, 9, 11 all are inactivated. At low concentrations of heparin, factor 10A mediated conversion of the prothrombin to thrombin is selectively affected. We will discuss about this, and the anticoagulation action is exerted mainly by the inhibition of the factor 10A as well as thrombin. So heparin, long molecule of the heparin basically inhibits both thrombin as well as the factor 10A. So you can see this coagulation pathway, and these are the red ones are the heparin. So heparin mainly blocks the conversion of this common pathway as well as the intrinsic pathway. So when this common pathway is ultimately blocked, there will be retrograde inhibition of this intrinsic pathway. So first this is blocked, and then by means of the feedback inhibition, this 11A, 11 to 11A, 10 to 10A, 9 to 9A, all these activation of the coagulation factors are blocked by the heparin. So how this heparin action happens? So this is the important part. So you can see this is the unfractionated heparin, this violet color. So this is a long molecule, you can see approximately 10,000 to 20,000 unfractionated, that is it is not fractionated in the laboratory. When this unfractionated heparin is given to the body, there is already antithrombin is present, okay, in our plasma. This antithrombin acts with the thrombin very slowly to inactivate this thrombin. Thrombin means factor 2A. So this inactivation of the already present antithrombin to the thrombin is very slow. Now when this heparin is given, long molecule, on one side there will be when they are attached with one another, there will be a conformational change. So you can see this is one conformation, there will be change in the conformation from rectangle to triangle like this to show this. So when there is conformational changes in this antithrombin molecule, this antithrombin molecule becomes more propensity to attach the factor 10A. On the other side, since these are the large molecules, they basically provides a scaffolding within this thrombin and antithrombin ultimately binds to one another more speedily, more acceleratively. Okay. So you can see this is the antithrombin already present in plasma. This is the heparin molecule, and within the heparin molecule, the active part is the pentasaccharide sequence, the 5 saccharides units. This is the active part. So apart from this active part, when this is attached with this antithrombin, this heparin, ultimately there will be conformational change in the active site. so that there will be more attachment of the antithrombin with the factor 10A. When there is attachment of the more speedy attachment of the antithrombin with factor 10A, there will be inactivation of the factor 10A. One hand. On the other hand, these long molecules provides a scaffolding. Within this scaffolding, there will be more interaction between the thrombin and antithrombin, more accelerated interactions, and ultimately this thrombin is also inactivated. So when the unfractionated heparin is used, there will be inactivation of both thrombin, that is the factor 2A, as well as the factor 10A, remember. Now what happens when we are using this unfractionated heparin? There will be different types of the adverse effects, that is there will be more chances of the bleeding, there will be more chances of the thrombocytopenia, we need more monitoring. So in the laboratory it has basically become fractionated, so that these long molecules are fractionated, so that it will be a small molecules that contains the active pentasaccharide molecule. This pentasaccharide form is the active form. So when this low molecular weight heparin is used, basically in the similar way like this, there will be conformational change in the antithrombin molecule and ultimately inactivation of the factor 10. But since this is a small molecule, it does not provide a long scaffolding around both the thrombin and antithrombin. That's why when a low molecular weight heparin is used, there will be no or minimal inhibition of the factor, that is the thrombin or factor 2A. So you can see when the low molecular weight heparin is used, there will be conformational change and the factor 10A is inhibited, but there will be no scaffolding like this. Large scaffolding is not present, this one. That's why thrombin inhibition will not happen or will happen very minimally. Similarly, pentasaccharide, synthetic pentasaccharide molecules are also formed in the laboratory from the heparin that contains only this pentasaccharide part without any side chain. So again, when this pentasaccharide form attaches with the antithrombin, there will be conformational change and there will be more binding of this factor 10A, factor 10A and its inhibition, and there will be very lesser inhibition of the factor 2A or thrombin. So it is clear. So how the difference between the unfractionated heparin, low molecular heparin, or similar to the low molecular heparin, the synthetic pentasaccharides act. So this is the mechanism of action. This is very important. If you understand, so it will be clear. So again I am repeating. So basically heparin does not have its own intrinsic activity as anticoagulant. They basically accelerates the already present antithrombin to binding of the different clotting factors. Now this heparin is a very long molecule, normal heparin, and when this heparin is given, that heparin ultimately binds with the antithrombin. This antithrombin is already present in our plasma and it slowly inactivates the factor 10A, factor 2A, etc. very slowly. But when this heparin is given, when they attaches with the antithrombin, there will be conformational change, so that there will be more propensity of the factor 10A to attach with this antithrombin and becomes inactivated. And since this unfractionated heparin molecule is very large, so they basically provide a scaffolding, a long scaffolding. Within this there will be more interactions, very accelerated interactions between the thrombin and antithrombin. So unfractionated heparin blocks both factor 10A as well as the thrombin or factor 2A. But when we are cleaving this unfractionated heparin to small molecules like low molecular weight heparin or some synthetic pentasaccharide, that pentasaccharide form is the active form that is mainly responsible for the conformational change. When this is given, they are causing the conformational change, so there will be more inactivation of the factor 10A. But since this is a small molecules, there will not be any scaffolding, so there will not be any interactions between the thrombin and antithrombin. So they basically blocks only the factor 10A but will not inactivate the thrombin. So it is clear. So when we are using the low concentrations of the heparin, low concentration means again the side chain will be lesser. So they prolong APTT without significantly prolonging the prothrombin time. So APTT is activated partial thromboplastin time, that mainly indicates the intrinsic pathway, and the prothrombin time is the extrinsic pathway. So when the low concentration is given, only the common pathway and intrinsic pathway are mainly inactivated, the coagulation factors. But when high concentration of heparin given, that causes more scaffolding, more blockage of all the coagulation factors, so that there will be prolongation of both APTT and the proton mean time, that is the activated partial thromboplastin time as well as the proton mean time. So the same thing, the low concentration interferes selectively with the intrinsic pathway, affecting amplification and continuation of the clotting, while high concentration affect the common pathway as well. So the same thing what we have discussed. So heparin enhances the action of the antithrombin tree in two ways. Long heparin molecule provides a scaffolding for the clotting factors, mainly factor 10A and 2A or thrombin, as well as antithrombin tree to get bound and interact with each other. And the next is heparin induces conformational change in antithrombin tree to expose these interactive sites so that there will be more binding. So it is clear, this is very important, this is complex, but if you can understand, it is easier. So the questions will come that what is the difference of the mechanism of action between the unfractionated heparin and the low molecular weight heparin? Why the unfractionated heparin blocks both the clotting factors, and why the low molecular weight heparin or the synthetic pentasaccharides blocks only the factor 10A? Different types of the questions from different areas can come. If the mechanism of action is clear, you can write. So any doubt about the mechanism of action of the heparin? So the same thing, just remember these pictures, it will be easier. So heparin actions, it also acts in higher doses as antiplatelet. Some action is there, lipemia clearing, that is injection of heparin ultimately clears the postprandial lipemic plasma. Details is not required. It is highly ionized, strongest organic acid, not absorbed orally. It has to be given by intravenous or subcutaneous route. Subcutaneous route is slow action and intravenous is the instant action. It does not cross the blood-brain barrier and placenta. That's why if the anticoagulation is needed in the pregnant women, we have, or the breastfeeding women, we have to give the heparin. So 100 unit per kg dose, half-life is 1 hour, but above this dose 1 to 4 hours, should not be given with penicillin, hydrocortisone or tetracycline. So there are some drug interactions are there. Now coming to the adverse effects of the heparin. So since this is anticoagulant, so always there is chances of the bleeding, just opposite of the coagulation. And with the unfractionated heparin, with the long molecules of the heparin, since there is more inactivation of the different clotting factors, so there will be more chances of the bleeding with the unfractionated heparin. But when we are cleaving this to the smaller molecules, the chances of the bleeding will be less. Thrombocytopenia can also happen due to aggregation of the platelets. Another term is the heparin-induced thrombocytopenia, that is also problematic. Hypersensitivity like urticaria, rigor, fever, anaphylaxis can happen. Transient or reversible alopecia can happen. Osteoporosis, that is fragility of the bone is increased. This is also very common adverse effect of heparin, and some hypersensitivity reactions are there. So adverse effect of the heparin. So heparin-induced thrombocytopenia, it is a separate entity, and that can happen with some patients where the heparin is transfused. So basically it is a potentially devastating adverse drug reaction caused by the emergence of antibodies that activates the platelets in the presence of heparin. Basically this is a two type of the heparin-induced thrombocytopenia, type 1 and type 2. Type 1 is the non-immune heparin-induced thrombocytopenia. This is non-immunologic response mediated by a direct interaction between the heparin and circulating platelets. So there will be interaction heparin and the platelets, and there will be platelet clumping, and that are sequestrated. So this type 1 affects up to 10% of the patients, usually occurs within the first 48 to 72 hours after initiation of the heparin treatment. And type 2 is the immune mediated, where the antibody is developed. It starts somewhat slowly, typically occurs 4 to 10 days after exposure to heparin, and has life and limb threatening thrombotic complications. So you can see that the heparin is an anticoagulant, but in some of the cases there may be thrombotic complications also when the heparin induced thrombocytopenia develops. So this is the mechanism by which the heparin induced thrombocytopenia, particularly the type 2, which is the devastating condition and which happens in 90% of the heparin induced thrombocytopenia patients. So this is the heparin, and there is one molecule, this is the platelet factor 4. This is also present on the platelet, released from the platelet. So heparin now binds with the platelet factor 4, and basically this acts as a immunogen. So immunogen means within against this antibody can be formed. So this is the outside molecule, it acts as a immunogen, platelet factor 4 and heparin complex. So IgG antibodies are formed against this, and this IgG antibody binds with this platelet factor and heparin and forms a platelet factor 4 heparin IgG complex. A immunogenic complex is formed via the Fc receptor. Now this, when this complex is formed in the platelet, there is Fc receptor is present, they attaches with the platelets, and when the platelets attachment of this immunologic molecule happens, there will be platelet activation. So platelet activation means from the platelet different mediators are released. So at the first we have read about the platelet activation, aggregation, etc. So platelet starts releasing ADP, different types of the molecules that adhere to one another, and the platelet clumping starts. So these are basically prothrombotic microparticles. These are because they causes the thrombosis, clumping of the platelets, different types of the platelets. So immune complex interacts with this endothelial cells, they also interacts with the endothelial cells. This is the endothelium, and ultimately endothelial damage can also happen. So this platelet clump develops from the platelets, different prothrombotic microparticles are released. This platelet clump also attaches with the endothelium because it is present within the blood, platelets. When it is attaches with the endothelium, so there will be endothelial breakage, and ultimately when there is endothelial breakage, again the clumping, clotting, all these factors ultimately comes forward to mingle the blockade. So ultimately there will be thrombus formation. So by this is known as the heparin induced thrombocytopenia with thrombosis. So HITT, this is also known as the. So now coming to the contraindications of the heparin, what the heparin cannot be given. First is the bleeding disorder. So there are different types of the bleeding disorders are there. So in those cases, because it is an anticoagulant, so that there will be more chances of the bleeding. History of the heparin induced thrombocytopenia. So if there is previous history that the patient has given transfusion of the heparin and there will be thrombocytopenia, so it should not be given. Severe hypertension, so there will be risks of the cerebral hemorrhage is there. Threatened abortion, piles, gastrointestinal ulcer, because there is risks of aggravated bleeding. So in these cases, subacute bacterial endocarditis, these patients are more prone for the embolism, so thromboembolism can develop when the heparin is given. Large malignancies, mainly the solid malignancies where the risks of bleeding in the central necrous part is more. Tuberculosis, there is risks of hemoptysis. Ocular and neurosurgery, lumbar puncture, in all these cases there are more chances of the bleeding. Chronic alcoholics, cirrhosis and renal failure, because the kidney and liver are already compromised. Aspirin and other antiplatelet drugs should be used very cautiously during heparin therapy, because these are the antiplatelet drug and heparin is the anticoagulant. So together if this is given, so there may be chances of the bleeding. So these are the contraindications of the heparin. Now coming to the low molecular heparin, already we have discussed about the mechanism, how the low molecular heparin acts. So they are fractionated in the low molecular forms from the approximately 15,000 to 20,000 molecular weight to approximately 3,000 to 7,000 molecular weight in the laboratory by means of cleaving. They have a different anticoagulation profile, selectively inhibit factor 10A with very little effect on the factor 2A or the thrombin. Already we have discussed about this. They act only by inducing the conformational changes in the antithrombin tree and not by providing a scaffolding for interactions, already discussed. So these low molecular heparins have smaller effect on the APTT, that is the activated partial thromboplastin time, and the whole blood clotting time than the unfractionated heparin relative to the antifactor 10A activity. So that there will be, since there is lesser effect on the APTT, lesser effects on the prothrombin time, so that the adverse effects are also less with the low molecular heparin rather than the unfractionated heparin. They have lesser antiplatelet action also, less interference with hemostasis, thrombocytopenia is less frequent. So for the disease where we need the heparin, basically it has been seen that we don't need very high grade of the anticoagulation that is usually possible with the unfractionated heparin. So the low grade of the anticoagulation that is possible with the low molecular weight heparin or the synthetic pentasaccharides is enough for the prophylaxis or the treatment of the different cardiovascular or cerebrovascular diseases. So the same thing, just for recapitulation, the same thing. So a lower incidence of the hemorrhagic complications compared to the unfractionated heparin is there. So hemorrhagic complications, bleeding is lesser. They are eliminated primarily by renal excretion, not to be used in patients with renal failure. Better subcutaneous bioavailability. Usually the low molecular weight heparin is given by subcutaneously twice or thrice weekly. 70 to 90% compared to unfractionated heparin, the bioavailability is very less, 20 to 30%. That's why large amount is also to be transfused. Variability in response is minimized. Longer and more consistent T-half. The half-life is more consistent, 4 to 6 hours. So once daily subcutaneous or once weekly, twice weekly, thrice weekly, according to the disease can be done. APTT or clotting time are not prolonged. So laboratory monitoring is not needed. So when we are using the unfractionated heparin, usually everyday laboratory monitoring is needed to see whether there will be no bleeding or not. But when we are using the low molecular weight heparin, usually everyday monitoring is not needed. Risk of osteoporosis after long-term use is much less with low molecular weight heparin compared to unfractionated heparin. So this is a very important question. That is why the low molecular weight heparin are usually preferred over the unfractionated heparin. Or what are the advantages of the low molecular weight heparin over the unfractionated heparin? So you have to write everything. Okay. So this is better subcutaneous bioavailability, more consistent T-half, monitoring is not needed, the mechanism of action, etc., etc. The bleeding time is not prolonged like this. And it is equally efficacious to unfractionated heparin except in cardiopulmonary bypass surgery. In cardiopulmonary bypass, we need a high grade of the anticoagulation. That's why we need the unfractionated heparin. Apart from this, in all of the cases, we are basically using the low molecular weight heparin. So indications are prophylaxis of the deep vein thrombosis and pulmonary embolism in high risk patients undergoing surgery, stroke or other immobilized patients. So when their patient is immobilized for a long period of time, there is always chances of the deep vein thrombosis, that is thrombus formation within the deep veins. Ultimately, that can lead to some limb-threatening consequences. So in those cases, we have to use this heparin or low molecular weight heparin. Treatment of the established deep vein thrombosis, that is, you can see both the prophylaxis and treatment of the deep vein thrombosis. Unstable angina and myocardial infarction. So if the infarction already happened or there is angina, unstable angina, they have largely replaced continuous infusion of the unfractionated heparin to maintain patency of the cannula and shunts in dialysis patients. In dialysis, so that there will be no thrombus formation within the cannula, we can use the heparin. Fondaparinux is more or less similar to the low molecular weight heparin. So basically bioavailability is approximately 100%, longer acting 17 hours, metabolism is minimal, less likely to cause thrombocytopenia, does not require laboratory monitoring of the APTT, longer acting alternative to low molecular weight heparin. So it is a synthetic pentasaccharide. So only the pentasaccharide portion, that is the active moiety, that is synthesized within the laboratory. Name is the fondaparinux. Danaparide is another type, that is basically a mixture of the heparin, darmatan and chondroitin sulfates. Previously this was used, that is lesser used nowadays. It also exerts its anticoagulant effect predominantly by inhibiting factor 10A and to a much lesser degree thrombin. Again, it has 100% bioavailability. Next, coming to the direct thrombin inhibitor. So heparin is basically, you can say, indirect thrombin inhibitor. So they are acting indirectly. They do not have a intrinsic anticoagulant effect. But this direct thrombin inhibitor, they have intrinsic anticoagulant effect. So they bind directly to the thrombin and inactivates it without the need to combine with and activates the antithrombin tree. So they do not need the binding with the antithrombin tree, they are directly blocking the thrombin. That's why they are known as the direct thrombin inhibitor. So lepirudin is the first one, prototype 1 direct thrombin inhibitor. Lepirudin is a recombinant preparation of hirudin. So hirudin, you have know, hirudin is obtained from the leech. A polypeptide anticoagulant secreted by the salivary gland of the leech. Jonk. Leech's salivary gland take hirudin bearer. That's why when leech is attaches to your foot, you will not, there will be no sense that it will be sucking blood, and when it will be content with the blood, ultimately it goes away. So there will be this, due to the presence of this hirudin, there will be continuous blood coming out from the wound side, because when there is wound, our normal physiological response is always the activation of the coagulation cascade, platelets, etc., and there will be coagulation and platelet plaque formation. But when this hirudin or this congeners are given, this coagulation cascade or the will not continue. That's why this acts as an anticoagulant. So from this lepidotide is formed. It binds firmly to the catalytic as well as substrate recognition sites of the thrombin and inhibits it directly. So here no use of the antithrombin. This antithrombin is already present in the plasma. They are directly attaches with the thrombin. There are different sites of the thrombin where they attaches, like catalytic site, substrate recognition site. Injected IV, it is indicated only in patients who are at a high risk of heparin induced thrombocytopenia. Basically these are used in different types of the heparin induced thrombocytopenia or heparin induced thrombocytopenia with thrombosis. On repeated or prolonged administration, antibodies against the lepidotide thrombin complex again may develop that result in prolonged anticoagulant effect and possibility of the anaphylaxis. So action cannot be reversed by any antidote. That's why this lepidotide is lesser used nowadays. We are more using the bivalirudin and argatroban. These are the newer ones, newer direct thrombin inhibitor. Mainly the indications of this direct thrombin inhibitor is the heparin induced thrombocytopenia or heparin induced thrombocytopenia with thrombosis. So bivalirudin is a smaller peptide prepared synthetically. Action is similar to lepidotide. Its action is slowly reversible due to cleavage of its peptide bonds by thrombin itself. And argatroban is a synthetic non-peptide compound. It binds basically reversibly with the catalytic site but not to the substrate recognition site. So it produces rapid and short-lasting antithrombin action. Because the action, if it is prolonged, ultimately that leads to different types of the adverse effect. It can be given by IV infusion, indicated again in heparin-induced thrombocytopenia. So just remember the name lepidotide, bivalirudin and argatroban, of which bivalirudin and argatroban are used. The indication is the heparin-induced thrombocytopenia. This is the heparin antagonist, that is the protamine sulfate. So protamine sulfate, this is again, since the heparin is the strongest organic acid, this is one of the strong base present in our body. Strongly basic, low molecular protein. Again, it can be crystallized and the drug can be formed. It neutralizes heparin weight by weight. 1 milligram is needed for every 100 unit of the heparin. Mainly it is used for heparin induced bleeding. Most commonly used when heparin action needs to be terminated rapidly after cardiac or vascular surgery. Basically this protamine is an orphan drug, very lesser used now. It is not available everywhere. It is used when the unfractionated heparin is used. Mainly it is used in the cardiopulmonary bypass surgery or the long surgery where the high grade of the anticoagulation is needed. But after that we have to reverse the patient. For this we have to use the protamine sulfate. But it does not neutralize fondaparinux. In the absence of the heparin, protamine itself acts as a weak anticoagulant by interacting with platelet and fibrinogen. And the problem is it can release histamine in the body because it is a a strong base. That's why some anaphylaxis can happen. So remember heparin antagonist, it will be commonly asked protamine sulfate, used to reverse the action of the heparin, particularly the unfractionated heparin. So these are the factors affected by the heparin. So already we have seen. And vitamin K dependent factors, the yellow ones are the vitamin K dependent factors, already we have seen, factor 2, 7, 9, 10. They can be basically blocked by the oral anticoagulants. So now coming to the oral anticoagulants. Until now we have discussed about the parenteral anticoagulant, which can be given by intravenous or subcutaneous route. Oral is coumarin derivative like bis-hydroxycoumarin, warfarin sodium, acinocoumarol and ethyl bisocoumarin acetate, of which the warfarin sodium is the most commonly used and is the prototype drug. And phenandan is another enandan derivative, lesser used nowadays. So we have to read about everything about the warfarin. So warfarin and its congeners act as anticoagulants only in vivo. So already we have seen that heparin can act in vivo and in vitro both, but these oral anticoagulants act only in vivo, that is within our body. They act indirectly by interfering with the synthesis of the vitamin K dependent clotting factors. So vitamin K dependent clotting factors are 2, 7, 9, 10. So basically they are blocking this. They apparently behave as competitive antagonists of the vitamin K. So already we have seen about the vitamin K, phytonadione, menadione. So they are just antagonists of the vitamin K, lower the plasma levels of the functional clotting factor. So how it acts? So this is the mechanism of action of the warfarin or the other oral anticoagulants. So this is the vitamin K. So vitamin K epoxide is converted to vitamin K hydroquinone, and again it is converted to vitamin K epoxide, and this conversion goes on. When this vitamin K hydroquinone is converted to vitamin K epoxide by means of the gamma glutamine carboxylase, the non-active descarboxy prothrombin or factor 7, 9, 10, they are converted to its active moiety. That is the factor 2, 7, 9, 10. So you can see this cycle is needed for the conversion of the inactive moiety of these coagulation factors to convert to the active moieties. Inactive moiety is the descarboxy forms, and these are the active moiety. Again, if the cycle is to be continued, the vitamin K epoxide again have to be converted to the vitamin K hydroquinone, and it continues within our body. And here the NADH is converted to NAD, and again the vitamin K hydroquinone is converted to vitamin K epoxide. Now when we are using the warfarin or other oral anticoagulants, they basically blocks the vitamin K epoxide reductase enzyme that is needed for the conversion of vitamin K epoxide to vitamin K hydroquinone as well as NADH to NAD, and that is needed for the generation of the inactive coagulation moieties 2, 7, 9, 10 to active coagulation moieties 2, 7, 9, 10. So it is clear. So warfarin is basically blocking the vitamin K epoxide reductase, and by this it acts like an vitamin K antagonist. So it is clear how it acts. Now this factor 7 has the shortest plasma half-life. So they are blocking 2, 7, 9, 10. So different clotting factors have different types of the half-lives. The factor 7 shortest half-life 6 hours. So its level falls fast when the warfarin is given, followed by the factor 9 whose T-half is the 24 hours. Then factor 10 T-half is the 40 hours and prothrombin is the 60 hours. So when we are using the warfarin, first the factor 7 level drops. Though the synthesis of the clotting factor diminishes within 2 to 4 hours of the warfarin administration, anticoagulation effect develops gradually over the next 1 to 3 days as the levels of the clotting factors already present in the plasma decline progressively. That is, there is already presence of some clotting factors that ultimately acts. So when we are using the warfarin, so there will be a delay in showing the anticoagulation effects approximately 1 to 3 days. That's why when we need immediate anticoagulation, we have to start with the heparin. Basically, when in myocardial infarction patients or some patients, we have to start both with heparin as well as the warfarin. Heparin causes the immediate anticoagulation, helps in the immediate anticoagulation. So after 2 to 3 or 4 days, heparin can be stopped and the warfarin can be continued, because warfarin takes over the action of the heparin in anticoagulation. So this is clear. Since there is already synthesized clotting factor is present within the plasma, and there are different half-lives of these clotting factors, factor 7, 2, 7, 9, 10. So they basically drops one after first factor 7 drops, then factor 10 drops like this. So all the dropping of these coagulation factors takes approximately 1 to 3 days. So minimum 1 to 3 or 4 days is needed for the manifestation of action of the warfarin. So there is always a delay between administration of these drugs and an anticoagulant effect. This is very important. And again, therapeutic effect occurs when the synthesis of the clotting factor is reduced by the 40 to 50%. So clinically significant anticoagulation is needed when approximately 40 to 50% of the clotting factor synthesis is inhibited. So if there is somewhat inhibition of approximately 10% or 20%, there will not be any clinically significant anticoagulation. The commercial preparation of the warfarin is basically contains 2 enantiomers. One is the dextrorotatory and there is the levorotatory. So hence this is also known as the racemic warfarin sodium. The S form is the more potent, metabolized relatively faster by ring oxidation by cytochrome P2C9, R form is less potent, degraded by side chain reduction by 1A and 3A4. It is rapidly and completely absorbed from the intestine, 90% plasma protein bound, crosses placenta and secreted in milk. So warfarin crosses placenta, that's why warfarin is not to be given in pregnant women. So if you are asked what is the anticoagulation of choice in pregnancy, that is the answer is the heparin. And again, warfarin is very highly plasma protein bound. If we are asked a high plasma protein bound drugs example, this is the warfarin. And warfarin is metabolized by the different cytochrome enzymes. So there will be very much interactions between the different other drugs, different other foods, etc. INR international normalized ratio, probably you have read in the pathology about the INR prothrombin time. So INR is basically a marker by which we can see how the warfarin or other oral anticoagulants are acting. So this is the international normalized ratio, optimum ratio of the prothrombin time during treatment with the oral anticoagulant to the normal value. This value differs depending on whether rabbit brain or human brain thromboplastin is used. Since there is difference in different laboratories about the clotting or tendency of this warfarin, so international normalized ratio has been proposed. So this is the international normalized ratio. Patient's prothrombin time in seconds by mean normal prothrombin time in seconds to the power of ISI. ISI is the international sensitivity index that is fixed in different age groups for different ethnic people. So from this we can determine the INR and accordingly the dose of the warfarin can be increased or decreased. Usually for the different diseases we have to keep the INR, for example, between the 2 to 3 or 3 to 4, and accordingly if it is lesser or if it is higher we have to decrease or increase the dose of the warfarin. Adverse effects, bleeding, again like that of the heparin, since this is the anticoagulant there is always chances of the bleeding. Extension of the desired pharmacological action, echymosis, epistaxis, hematuria, bleeding in the gastrointestinal tract, all can happen. Intracranial internal hemorrhage can also happen. Bleeding is more likely if therapy is not properly monitored. So in warfarin therapy we have to monitor continuously with the prothrombin time as well as the INR. And we read about the novel oral anticoagulants that usually do not need this monitoring. So if the INR exceeds 4, so there will be more anticoagulation, so interacting drugs and contraindications are present, so there will be more chances of the bleeding. Alopecia, dermatitis, diarrhea can happen, and there is one typical adverse effect of the warfarin induced skin necrosis. It is a rare but serious complications of the warfarin. Prevalence is very less, but it can occurs 2 to 5 days after initiation of the warfarin, usually occurs after high dose. So this is the warfarin induced skin necrosis. So if you are asked about the adverse effect of the warfarin, so bleeding from the different areas, and if it happens the INR is very high, and also warfarin induced skin necrosis, that is very important. Due to oral anticoagulants, so when there is bleeding we are using the warfarin. So we have to stop the anticoagulant, we have to stop the warfarin, give the fresh blood transfusion, because this fresh blood transfusion supplies the clotting factors and replenishes the lost blood. Alternatively, FFP, that is the fresh frozen plasma, can be given, that also contains all the clotting factors. Vitamin K1 is the specific antidote. So phytonadione, vitamin K1, which is the specific antidote of the warfarin. But again it takes 6 to 24 hours for the clotting factors to be resynthesized and released in blood after the vitamin K administration. So if you are asked what is the antagonist, what is the specific antidote of the warfarin toxicity, that is the vitamin K1 or phytonadione. But again we have, when there is warfarin toxicity, we have to give first some fresh blood transfusion or the fresh frozen plasma, because again it takes some days to generate the coagulation factors. So dose regulation, it must be individualized by repeated measurement of the prothrombin time and the INR international normalized ratio. The aim is to achieve a therapeutic effect without unduly increasing the chances of the bleeding. So you can see these are some examples. This ultimately changes in different guidelines. So recommended INR if there is prophylaxis of the deep vein thrombosis and similar indication. Prophylaxis is needed when there is cancer or prolonged immobilization after surgery or some long-standing surgery, etc. So we have to keep warfarin in such dose so that the INR will be between 2 to 2.5. Similarly, treatment of the deep vein thrombosis or pulmonary embolism or transient ischemic attacks, hip surgery, which is a very prolonged surgery, again 2 to 3 INR is needed. Recurrent thromboembolism, arterial disease like myocardial infarction, prosthetic heart valves. In these cases, we need more anticoagulation, so INR is approximately 3 to 3.5 is needed. So, if there is myocardial infarction, recurrent thromboembolism, we need more. INR is to be kept between the 3 to 3.5. So, we have to monitor the proton mean time, and there is formula by means of the patient's proton mean time, we can calculate the INR. INR calculation usually 2 to 3 should be there. If the INR is very less than 1, again the dose is to be increased. If the INR is very high, dose is to be decreased. And there are different factors that enhances the effect of warfarin or decrease the effect of the oral warfarin. For example, debility, malnutrition, malabsorption, liver disease, chronic alcoholism, hyperthyroidism, newborns, because they have low levels of the vitamin K, they basically enhances the effect of the warfarin, while the pregnancy, where the plasma levels of the clotting factor is higher, nephrotic syndrome, where the drug bound to plasma protein is lost in the urine, and there may be some genetic warfarin resistance. The affinity of the warfarin as well as the vitamin K epoxide to bind to the reductase enzyme which generates the activate vitamin K hydroquinone is low. So, it had been seen that in some persons, in some ethnicities, there may be some resistance to the warfarin action because the warfarin cannot act. So, in these cases, the dose of the oral anticoagulant is needed 4 to 5 times higher. So, here the factors decrease the effect of the warfarin. Contraindications of the warfarin, more or less same as heparin, only one thing is to be added, that is the fetal warfarin syndrome, because the warfarin cannot be given in pregnancy. If it is given in pregnancy, it causes the birth defects, especially the skeletal abnormalities, hypoplasia of the nose, eye sockets, hand bones, growth retardation, all can happen. If it is given in latter part of the pregnancy, it can cause CNS defects, fetal hemorrhage, fetal death, and accentuates neonatal hypoproteinemia. And other contraindications are similar to that of the heparin, because it is used in the similar indications. So, drug interactions are always there. Drug interactions, details is not needed, but remember, if warfarin is given, we have to think about the different types of the drug interactions, drug food interactions, etc. can happen. Different types of the antibiotics can interact. Aspirin, because they have platelet aggregatory effect, they can interact. Long acting sulfonamides, indomethacin, chloramphenicol, erythromycin. So, these are the different antibiotics. They can interact. Reduced anticoagulation action can affect due to the barbiturate, carbamazepine, rifampicin. Oral contraceptives, this is important, it increases the blood levels of the clotting factors, so it can reduce the anticoagulant action. So, this is about the warfarin. From the next class, we will discuss about the novel oral anticoagulants and the other drugs like antiplatelet drugs, fibrinolytic drugs, antifibrinolytic drugs, etc. So, from the today, the most important part is the heparin and the warfarin. So, you have to read everything about the heparin and the warfarin. This is a very important question.